Hello everyone, welcome to our latest talk, where we will explore metronomic low-dose chemotherapy for prostate cancer. Metronomic chemotherapy is an innovative approach that involves the continuous administration of low doses of conventional chemotherapy drugs, typically taken orally on a daily basis without scheduled breaks. This method is known for its antiangiogenic and immunomodulatory effects on tumors, making it a game changer in cancer treatment. One of its most appealing aspects is its superior toxicity profile, compared to the standard maximum tolerated dose chemotherapy, offering patients a gentler alternative. In prostate cancer, metronomic low-dose chemotherapy has shown promising results. Over half of the patients have experienced either a response in PSA levels or stability, indicating a significant clinical benefit. Additionally, this therapy stands out as a cost-effective and well-tolerated option, particularly for older patients, or those who are unfit, for more aggressive treatments like taxane chemotherapy. Today, we're going to explore how metronomic low-dose chemotherapy is making strides in the treatment of metastatic castration-resistant prostate cancer, offering a viable alternative for those seeking a less intensive treatment option. So, stay tuned as we uncover the potential of this groundbreaking therapy.
The information provided in this content regarding low-dose chemotherapy for prostate cancer is for educational and informational purposes only. It is not intended as medical advice or as a substitute for professional medical consultation, diagnosis, or treatment. The effectiveness, risks, and benefits of low-dose chemotherapy for prostate cancer can vary widely among individuals, and it is essential to discuss all treatment options, including the risks and potential side effects, with a qualified healthcare professional. An oncologist or medical professional who is familiar with your individual medical history and current health status is the best source of advice for your specific situation. We strongly recommend consulting your oncologist or healthcare provider before considering any changes to your medical or treatment plan. This content does not endorse any specific tests, physicians, products, procedures, opinions, or other information that may be mentioned. Reliance on any information provided in this content is solely at your own risk.
Now, let's turn our attention to prostate cancer. A significant breakthrough came with the introduction of docetaxel, a semi-synthetic taxane, in the treatment landscape. Its superiority over mitoxantrone was established through the pivotal Phase 3 study, known as TAX327, leading to its adoption as the standard of care in 2004. In this study, a total of 1,006 patients diagnosed with metastatic, castration-resistant prostate cancer were enrolled. They were randomly assigned to one of three treatment groups: mitoxantrone at a dose of 12 mg per square meter every 3 weeks, docetaxel at 75 mg per square meter every 3 weeks, or docetaxel at 30 mg per square meter weekly for 5 out of every 6 weeks. All patients across these groups also received prednisone at a dose of 5 mg twice daily. The results were compelling. The group receiving docetaxel every 3 weeks exhibited significantly longer survival, with a median survival of 19.2 months compared to the mitoxantrone group, which had a median survival of 16.3 months. Furthermore, it's worth noting that weekly docetaxel demonstrated substantial improvements in the quality of life for patients, when compared to mitoxantrone. However, it's important to mention that there was no statistically significant difference in survival between the weekly docetaxel regimen and mitoxantrone. As a result of the TAX327 study, docetaxel at a dose of 75 mg per square meter became the established first-line chemotherapy for patients with metastatic castration-resistant prostate cancer. This landmark study has significantly impacted the treatment landscape for this condition. As I previously mentioned, docetaxel, when administered every 3 weeks, constitutes a standard treatment for castration-resistant advanced prostate cancer. But intriguingly, new research points to biweekly schedules as potentially more efficacious. This information comes from the work of the Prostate study group in Europe, which compared the standard 3-week regimen to a 2-week cycle of taxotere. Their investigations revealed that the 2-week cycle holds an advantage over the traditional method. In their Phase 3 study, researchers divided patients into 2 groups. One received 75 mg per square meter of docetaxel intravenously at the start of a 3-week cycle, while the other received 50 mg per square meter on the 1st and 15th days of a 4-week cycle. Each patient also took 10 mg of oral prednisolone daily. The study included 177 patients on the biweekly regimen, and 184 on the 3-week cycle. The results were significant. The group on the biweekly schedule experienced a longer period before treatment failure, 5.6 months compared to 4.9 months in the 3-week cycle group. Moreover, the biweekly group saw marked improvements in overall survival and progression-free survival, critical indicators of the treatment's success in extending life and halting cancer progression. Additionally, the rate of severe adverse events, including febrile neutropenia, was higher in the 3-week cycle group, with a 14% incidence compared to only 4% in the biweekly group. Furthermore, the patient's quality of life, a paramount consideration, showed significant improvements. Those in the biweekly treatment arm reported better overall quality of life and less pain, according to patient-reported outcomes. This means the biweekly regimen not only extended lives but also enhanced the quality of those lives. To conclude, the findings indicate that a biweekly administration of docetaxel not only prolongs the time to treatment failure, but is also more favorably tolerated, presenting a promising alternative to the standard 3-week regimen. This could represent a paradigm shift in the treatment approach for those facing this formidable type of prostate cancer, particularly for patients who may not tolerate the standard dosing schedule. A Phase 2 study from South Korea explored a biweekly chemotherapy protocol, focusing on the use of docetaxel combined with androgen deprivation therapy, for treating metastatic castration-naive prostate cancer. The study's inclusion criteria was stringent, selecting patients with previously untreated metastatic prostate cancer. These individuals underwent treatment with androgen deprivation therapy, and docetaxel, administered at a dose of 40 mg per square meter. This treatment was given biweekly over a course of up to 12 cycles. The study registered a total of 42 patients, all of whom were closely monitored for outcomes. Over a median follow-up duration of 25 months, a notable 95% of the patients exhibited a PSA response, with the average lowest PSA level being 0.42 nanograms per milliliter. Additionally, the median cancer-free survival time was recorded as 26.4 months. The most frequent adverse event was anemia, reported in 95% of the patients. Other noted side effects included nail changes in 33% of patients, fatigue in 29%, and oral mucositis in 26%. Notably, severe adverse events, those classified as grade 3 or higher, were uncommon. In summary, the outcomes of this study indicate that the biweekly regimen of docetaxel, plus androgen deprivation therapy is a feasible treatment option. Crucially, its clinical efficacy seems comparable to the conventional triweekly regimen of docetaxel 75 mg per square meter, combined with androgen deprivation therapy. This finding suggests that the efficacy of treatment is not diminished by the biweekly schedule. We've seen data suggesting biweekly Taxotere might be more beneficial than traditional 3-week schedules. This naturally leads us to the efficacy of weekly metronomic chemotherapy in treating advanced prostate cancer. Indeed, over the last 30 years, various regimens of metronomic chemotherapy, using a weekly schedule, have been scrutinized in advanced prostate cancer patients. It is crucial to note that most of these studies occurred before the advent of new hormonal or cytotoxic agents, such as abiraterone, enzalutamide, apalutamide, darolutamide, and cabazitaxel. These novel treatments have significantly changed the therapeutic landscape. The benefits of metronomic chemotherapy have often been evaluated in smaller, non-randomized trials, or through retrospective analyses. Thus, it is not currently considered a standard treatment option for advanced prostate cancer. Yet, metronomic chemotherapy finds its niche as a therapeutic alternative for patients who have exhausted all available treatments, or those who are not suitable candidates for standard chemotherapy regimens. In fact, many studies have shown the efficacy of this approach in advanced prostate cancer patients. These studies not only demonstrated anti-tumor activity, reflected by a 30 to 50% decline in prostate-specific antigen levels, but also highlighted an exceptionally favorable safety profile. This is particularly relevant for elderly and frail patients, who constitute a significant portion of this patient population. For example, in a recent study by Dr. Kolvani, a combination of metronomic cyclophosphamide, dosed at 50 mg, with corticosteroids, either dexamethasone at 1 mg or prednisone at 10 mg, induced biochemical responses, specifically, at least a 50% reduction in PSA levels, in half of the participants. However, there is a caveat. Only one study has evaluated the activity of metronomic chemotherapy in patients previously treated with docetaxel and one or more novel endocrine agents. In this subset of patients, single-agent cyclophosphamide resulted in a relatively modest rate of PSA response, only 16%, with progression-free survival, and overall survival, averaging at 4 and 8.1 months, respectively. This suggests that the promising results observed prior to the era of new therapies may not be directly replicable in the current cohort of patients who have undergone standard treatments. In the realm of prostate cancer treatment, the classical approach of metronome chemotherapy, involving cyclophosphamide and low doses of corticosteroids, once showed promising results. This approach predates the widespread use of modern taxane-based chemotherapies. The question arises, does this older methodology still hold relevance in today's advanced treatment landscape for prostate cancer? To address this, two recent studies offer insight, one reinforcing its efficacy, while the other suggests a diminished response and survival rate. The first study of interest, conducted by Dr. Nicola Kolvani in Italy in 2019, centered on the effectiveness of this regimen in treating advanced or metastatic castration-resistant prostate cancer in the modern context of standard chemotherapies, like docetaxel and cabazitaxel, as well as newer hormonal treatments, such as abiraterone and enzalutamide. This retrospective analysis encompassed 37 patients. Each patient received an oral dose of 50 mg cyclophosphamide daily, complemented by a low dose of corticosteroids, either dexamethasone, 1 mg per day, or prednisone, 10 mg per day. The results were noteworthy. 51% of the patients experienced a PSA decline of 50% or more. The median progression-free survival and overall survival rates stood at 11 and 28 months, respectively. Impressively, for patients who achieved a PSA decline of 50% or greater, the median PFS and OS extended to 14 and 35 months, respectively. Furthermore, patients tolerated the treatment exceptionally well. Given these findings, the study posits that oral metronomic cyclophosphamide, paired with low doses of oral dexamethasone or prednisone, could be a viable and safe therapeutic option. This applies not only to CRPC patients who are unsuitable for standard treatments, but also to those who have undergone extensive prior treatment. Let's examine Dr. Cafo's retrospective analysis, which involved a cohort of 74 patients with CRPC. Each individual in this study was administered a daily oral dose of 50 mg of cyclophosphamide. The objective was clear: to assess the drug's activity in a group of patients who had already received, and not responded to, prior treatments. The results of Dr. Cafo's study are quite informative. Firstly, the treatment was generally well received, with patients showing good tolerability to the metronomic cyclophosphamide regimen. This is a crucial factor, as it means the treatment is potentially manageable over the long term. A notable 16% of the patients in the study experienced what we call a major biochemical response. This is evidenced by significant changes in the levels of prostate-specific antigen. In terms of survival metrics, the study reported a median progression-free survival time of 4.0 months, and a median overall survival time of 8.1 months. While these figures may not seem extensive at first glance, they are significant for a patient population that has already undergone multiple lines of therapy. Concluding the study, Dr. Caffo suggests that metronomic cyclophosphamide could be a valuable and cost-effective treatment option within the modern therapeutic landscape of metastatic CRPC. Although the efficacy may not match the more promising results seen in Dr. Kalvani's study, it's important to recognize the potential of cyclophosphamide as part of a tailored treatment strategy for certain patients with prostate cancer. Turning our focus to another innovative approach, in the treatment of metastatic castration-resistant prostate cancer, CRPC, let's discuss a study that examines the clinical activity of oral metronomic Vinorelbine, VNR, in combination with dexamethasone, DX. This protocol represents a different avenue of treatment, distinct from the cyclophosphamide-based regimen we previously discussed. The study in question aimed to investigate the effects of a regimen, combining 30 mg of oral Vinorelbine, administered 3 times a week, with 1 mg of oral dexamethasone, taken daily until the disease progressed. This treatment was given to 41 patients, a notable 92% of whom were resistant to chemotherapy, underlining the challenging circumstances of the study group. In terms of outcomes, there was a noteworthy finding: 35% of the patients experienced a decrease in prostate-specific antigen, PSA, levels of 50% or more from the baseline. This level of response is significant, particularly in a population with prior chemotherapy resistance. When we consider the survival metrics, the median progression-free survival, PFS, was recorded at 4 months, and the median overall survival, OS, extended to 17.5 months. These figures are particularly encouraging, especially given the context of the patient population's prior treatment resistance. An important aspect of any cancer treatment is the balance between efficacy and tolerability. In this study, the toxicity associated with the Vinorelbine and dexamethasone protocol was mild. Remarkably, no grade 4 toxicities were reported, which speaks to the treatment's safety profile. In summation, the combination of metronomic Vinorelbine and dexamethasone has demonstrated favorable activity and a low toxicity profile in patients with metastatic CRPC. These findings bolster the potential of metronomic therapies in managing advanced prostate cancer, providing a hopeful outlook for those who may not have responded to traditional chemotherapy. Now, let's examine a recent study that utilized the KEES protocol, a combination of 4 drugs, administered in a metronome fashion. The KEES regimen was structured into a 2-week cycle. During the initial week, patients received cyclophosphamide at 50 mg twice a day, along with ketoconazole at 200 mg, which was taken 3 times daily. In the second week, the treatment consisted of estromustine at 140 mg and etoposide at 50 mg, both administered twice daily. Additionally, prednisolone at a dose of 10 mg was provided once daily throughout the entire cycle. Significantly, all medications in this protocol were administered orally. The commencement of the treatment schedule was flexible, based on the physician's judgment. Options included a continuous regimen, a 6-week schedule with a subsequent 2-week intermission, or alternatively, a 2-week schedule followed by a 1-week rest period to facilitate patient recovery. Turning our focus to the outcomes of the KEES protocol, we find promising results within a cohort of heavily pretreated patients in the current treatment era. The protocol has been particularly noteworthy in its application to patients who have previously undergone extensive treatment, including at least 1 taxane and androgen receptor targeted agents, like abiraterone and enzalutamide. In the principal study group, the median overall survival was recorded at 12.3 months, with a median progression-free survival of 4.4 months. A biochemical response, indicated by a reduction in prostate-specific antigen, PSA, was observed in 29% of patients, while a decrease in any PSA levels was noted in 65% of the study population. Interestingly, progression-free survival appeared to remain consistent across various lines of treatment, whether patients had been previously treated with 1 or 2 taxanes, androgen receptor-targeted agents, or radium-223. This consistency in progression-free survival was mirrored by the biochemical response, which was evident across all patient subgroups evaluated in the study. Now, let's discuss the tolerability aspects of the KEES regimen, and navigate through the data together. In this study, of the 123 participants, 38 patients, which represents 31%, had to discontinue the treatment. The discontinuation was due to adverse events, or a worsening performance status, as measured by the Eastern Cooperative Oncology Group, or ECOG. The main adverse events leading to treatment discontinuation were bone marrow toxicity, fatigue, infection, and elevated liver function tests. Moving on to thromboembolic events, 20 patients, or 16% of the study group, experienced such events. Furthermore, 43 patients, representing 35% of the group, required hospitalization for various reasons. Infections were another concern, with 26 patients, accounting for 21% of the group, needing antibiotics or antivirals, including treatments for urinary tract infections. Notably, there were only 2 cases of febrile neutropenia. Lastly, the study reported 4 deaths during the treatment period. One of these deaths, upon review, was attributed to disease progression, and 3 were related to infections. It is worth mentioning that only one of these infection-related deaths occurred in a patient with grade 3 neutropenia. Understanding these statistics helps us grasp the risks associated with treatments, and underscores the importance of close monitoring for those undergoing such therapies. In conclusion, the KEES regimen emerges as a reasonable treatment strategy for those who have undergone significant previous treatment for metastatic castration-resistant prostate cancer, presenting manageable toxicity, and a higher biochemical response rate, compared to other similar late-line therapies. It's essential for clinicians to consider these factors when devising treatment plans for such patients.
As we wrap up today's discussion on metronomic low-dose chemotherapy for prostate cancer, it's clear that this approach is carving a new path in cancer care. Its ability to administer chemotherapy in a less aggressive, yet effective manner, particularly for patients battling metastatic castration-resistant prostate cancer, is truly revolutionary. The key takeaway from our exploration is the significant clinical benefits observed in patients, with over half experiencing positive changes in their PSA levels or maintaining stability. Moreover, the superior toxicity profile of metronomic chemotherapy compared to traditional maximum tolerated dose chemotherapy cannot be overstated. It offers a more patient-friendly treatment option, reducing the severity of side effects and improving quality of life. This is especially vital for older patients or those who might not be able to tolerate more intensive therapies. In conclusion, metronomic low-dose chemotherapy stands out as a cost-effective, well-tolerated, and potentially game-changing strategy in the fight against prostate cancer. It's a testament to the relentless pursuit of better, kinder treatments in oncology. As we continue to monitor the progress and advancements in this field, we remain hopeful for what the future holds. Thank you for joining us today, and please stay tuned for more insightful discussions on the latest developments in cancer treatment.